Hello. Today, we are taking a deep dive into one of the most challenging and frequently misunderstood sexually transmitted infections in modern clinical practice, Mycoplasma genitalium, or MGen. A recent supplement in Open Forum Infectious Diseases highlights why this pathogen causes so much confusion. MGen is often clinically silent, and because it lacks a cell wall, it is intrinsically resistant to beta-lactam antibiotics like penicillin. Furthermore, its extremely slow growth rate, taking weeks or even months to culture, means that traditional microbiology is virtually useless for real-time patient management. The diagnostic revolution. The landscape changed in 2019 when the FDA cleared the first nucleic acid amplification tests, or NAATs. We have moved away from culture and serology, which often cross-reacts with other Mycoplasma species, toward highly sensitive molecular targets. Currently, urogenital specimens are the primary diagnostic platform.
According to the FDA, cleared assays from Hologic, Roche, and Abbott, the preferred specimens are vaginal swabs for women and urine for men. If a woman tests negative on a non-preferred specimen like urine, but clinical suspicion remains high, guidelines recommend retesting with a vaginal swab for maximum sensitivity. A major milestone occurred in 2025 with FDA clearance and a CLIA waiver for the Roche Cobas Liat system. This is the first true point-of-care test for MGen, capable of delivering results for chlamydia, gonorrhea, and MGen in just 20 minutes. This technology finally enables same-encounter diagnosis and pathogen-specific treatment, a massive leap forward for public health. The antibiotic resistance crisis. However, our diagnostic success is being met by a secondary crisis, antimicrobial resistance. MGen has a very small genome, and a single mutation in its rRNA operon can confer high-level resistance. In some U.S. cohorts, macrolide resistance now exceeds 50%. Resistance to fluoroquinolones like moxifloxacin is also a growing global concern. Here is the critical gap. While international assays like the Resistance Plus test in Australia can detect resistance-associated mutations simultaneously with the infection, there are currently no FDA-cleared resistance assays available in the United States. This forces many U.S. clinicians to use sequential therapy, starting with doxycycline to reduce the bacterial load, followed by a second antibiotic, without knowing if the strain is actually susceptible. Global guideline comparisons. When we look at clinical guidelines globally, there is significant variation, though most are converging on a few key points. First, asymptomatic screening. Nearly every major health organization, including the CDC in the US, BASHH in the UK, and agencies in Europe and Australia, recommends against routine screening for asymptomatic individuals. The only notable exception is in the Canadian guidelines, which may consider it in specific high-risk circumstances. Second, symptomatic testing. You should prioritize MGen testing in cases of persistent or recurrent urethritis in men and cervicitis in women, especially if initial treatments for chlamydia and gonorrhea have failed. In the US, MGen testing is also considered for cases of pelvic inflammatory disease, or PID. Third, extragenital testing. While MGen is often found in the rectum, especially among men who have sex with men, its clinical significance there is still debated. Currently, the FDA has not cleared any NAATs for rectal or oropharyngeal MGen testing, and most guidelines only suggest rectal testing in cases of persistent proctitis. Special populations and partners. Special care must be taken with pregnant patients. Because the secondary treatment, moxifloxacin, is generally contraindicated in pregnancy, clinicians often face a dilemma when macrolide resistance is present. In many cases, if the patient is asymptomatic, guidelines suggest delaying treatment until after delivery. Regarding sex partners, the approach differs from that of chlamydia or gonorrhea. Because MGen is not always pathogenic, expedited partner therapy is not recommended. Instead, guidelines suggest that only ongoing sex partners should be tested, and then treated only if they test positive. Conclusion and stewardship. In summary, MGen management requires a shift in how we think about STIs. It is no longer just about finding and treating, It is about precision stewardship. We must resist the urge to screen everyone, which only drives further antibiotic resistance.
Instead, we should use the new, highly sensitive NAATs and the emerging point-of-care tests specifically for symptomatic patients where MGen is the likely culprit. As we wait for FDA-cleared resistance testing to reach the U.S. market, following regional guidelines is our best defense against making this difficult pathogen even harder to treat. For a detailed breakdown of the specific assays and a side-by-side comparison of international guidelines, I highly recommend reviewing the full supplement in Open Forum Infectious Diseases. Thank you for your time and your commitment to clinical excellence.